off the camera. Right, so tonight's talk is on cervical screening, the good, the bad, the ugly, and it's going to be a really interactive session tonight. Moving to the next slide. Click on the slide. This is my first time doing this tonight, so we're learning together. The Goodfellow unit is really focusing on trying to reach out to GPs and to provide user-friendly information and training for us. This is our new website, really excited about it, much more easy to access the variety of products that we are now producing. Most of you will know about our gems. These are very short, easy to read updates. Our podcasts, ideal for listening to in the car when you're driving to work or stuck in traffic. Our e-learning courses, really an opportunity to go much more in depth into an area. Notice the top one on dementia. This is a 5-hour course, but it really is an amazing look at dementia and how we work with our patients with this issue. The Goodfellow Med Talks, I'm promoting those. These are quick 13 to 15-minute talks with specialists to try and identify what is new. It's very, very user-friendly and very general practice or primary care specific. Now, let's focus on tonight. Tonight, you're going to have this sort of thing in front of you. And if you want to ask a question, you click the orange arrow and then you type in a question. I'll get it almost simultaneously and ensure that as much as we can, we get these questions answered by Jyoti. The other issue that we are going to do tonight is that we're going to ask you through the talk to give us some feedback. So Jyoti's going to say, when she shows a slide, is this a good, a bad, or an ugly? And if you can just type in G, B, or U, that will give us a sense of how many of you are thinking a particular cervix looks like a particular issue. So let's move on and start our lovely talk on the cervix tonight with Jyoti.
Thank you, Di. Okay, so my talk has 3 components. The majority of the talk is devoted to the appearance of the cervix, and that's what I divided into good, bad, and ugly. I'm going to touch briefly on the changes to the HPV immunization program, which started in January, the changes that happened in January this year, and the changes that you're going to have from next year in the cervical screening pathway. So why did I think it was important to do the good, bad, and ugly? When I audited our data of the cervical cancers we had in counties Manukau and Middlemore Hospital, we have a lot of referrals which are with a normal smear but an abnormal looking cervix. So a normal smear with an abnormal looking cervix, and not even one of them yielded a cancer. All the cancers we had in our population were high-grade cervical smear or cytological abnormalities. And that told me that we need some education around the naked eye appearance of the cervix so we can differentiate what is just good, which is a normal variant, a bad, which is an abnormal but a benign condition, and ugly, which is suspicious of malignancy. I wouldn't say cancer, but I would say suspicious of malignancy, because as I always say, the diagnosis of malignancy comes from a biopsy, not just by looking. You can suspect, but you don't get a definite answer. So the way the talk is laid out is I'm going to go through lots of slides of appearance of the cervix, and every slide I'm going to pause and give you an opportunity to tell us whether you think it is G, good, B, bad, or U, ugly. And then I move on to the next slide and tell you what it is. And as Di said, if you have any questions, please send us as we go, and I'll stop periodically to address those questions before moving on with my presentation. So normal cervix, we all agree this is a normal cervix. Now this is my first slide. a naked eye appearance of a cervix. Let's have the responses with G, B, U.
We're getting a great level of response. Thank you so much, everyone. And we're predominantly getting G's, a few B's, and the odd U.
Okay, that's good. That's good. Majority of us think it's a G. And that's my answer. It's a G. Now, what is it? Now, if you look at the cervix, that's the os, and you see this reddish area there, which sometimes can appear abnormal. But this is just a normal change. This is an ectropion. So if you look at the cervix, let's go back to the previous slide. If you look at the cervix, this is the ectocervix, or the outside of the cervix, which is lined by squamous epithelium and to the naked eye appears pink. If you look inside the cervix, it's lined by columnar and it appears red. What happens with certain hormonal changes? For example, if the woman's on the pill or otherwise hyperestrogenic state, this is what happens. The inside or the endocervix is exposed outside, which appears quite angry looking, but this is just a normal columnar epithelium which is exposed. This is an ectropion. That's a normal change. It's good. All this woman needs is reassurance and does not need a referral to the hospital. But just I would like to add here, when you're taking a smear from a cervix like this, if you touch just the columnar epithelium, you haven't really done an adequate smear. This is the area outside the columnar epithelium, outside the ectropion is the transformation zone, which is not visible to the naked eye, but you can know from the location of the ectropion that this is the area you need to sample to take a smear. If you take a smear just from here, you will get a satisfactory smear because it will pick up enough squamous cells, but you haven't even touched the transformation zone. So that's what we need to be careful about. And when you take a smear from a cervix like this, it is going to bleed. It will bleed. And that's normal. Columnar epithelium is very friable and it bleeds. So a normal. Now the ectropion can be all around, as in this cervix, or it can just be on one lip, as in this one, or in this. These are all normal variations of the cervix. That's the second slide. And here I want you to look at these yellow dots. If you look at these yellow spots, I want you to tell me whether you think this is good, bad, or ugly. Again, if you can respond by G, B, or U.
Hi, we've got a problem with someone not seeing the pictures.
Lots of good, some B's, okay. One U, okay, okay, okay. So let's see what this is. In my book, this is good. These are Nabotian follicles, which is a normal variation. In fact, when I'm teaching a colposcopy, when I'm teaching a trainee and I tell them how to recognize the transformation zone, one of the things I tell them is you look for the Nabotian follicles. When you find the Nabotian follicles, you know you're looking at the right area colposcopically. It's an absolutely normal change that happens in a cervix. So Nabotian follicles are normal. We get lots of referrals for Nabotian follicles. And sometimes when I read a description, I know what I'm going to find when I see this woman for colposcopy. A typical appearance of a Nabotian follicle is, if you focus on this Nabotian follicle, can you see the branching vessels on top? That's a typical appearance of a Nabotian follicle. So Nabotian follicles can be yellowish, as in this picture. Now this is a Nabotian follicles there, with an ectropion. So this is the margin of the ectropion. So this is a very normal cervix. Yes, it will bleed on smear taking, but if the smear is normal, this woman does not need a referral. She just needs to be reassured that it's a normal thing.
What are the preferred tools for taking a smear like this if you have ectropion?
Okay, let's go back so I can explain it better. If you see a cervix like this, I personally like a cervi broom. So have you all seen a cervibroom? Yeah.
They will have.
Yeah, so it's the blue handle with a white brush on top. So cervibroom is my preferred, instrument. So I would use a cervibroom. In women who are menopausal, I see them after treatment, or you see them 12 months after LEDS treatment, you must use an endocervical brush as well, because the transformation zone, the area to be sampled, is tucked inside the cervix. Now, in this woman, you do not need to use the cytobrush at all. At all. In fact, you should avoid it. All you're going to do is provoke more bleeding. So you have a cervibroom and you go around there. And also, if you put the long prong of the cervibroom here and just rotate it here, you're not going to touch the transformation zone. So I take a cervibroom and I actually sweep it in this area. That's what I do. And as we all know, you have to do it few times with the cervibroom to get enough cells. So I would just use cervibroom on this cervix. So the answer to your question, what is my preferred tool? My preferred tool is the cervibroom. Are there instances where I would combine it with a cytobrush? Yes. In menopausal women, where there's a very stenotic cause, or post-treatment, and also women on depot, it's quite useful to have a cytobrush because the transformation zones tuck right inside. So spatula, of course, is absolutely out. Spatula, if you have spatulas, please throw them away. Spatulas, liquid-based cytology just don't go together. Okay, that's the next slide. What do we think? Is it good, bad, or ugly?
Got a few more uglies coming in here. But we're hanging in with a few Bs as well.
And what do I think it is? Good. That's good. Okay. Why do I say good? It looks really awful looking cervix, but if you focus on this, that's just a really big Nabotian cyst. Nabotian, Nabotian, Nabotian. Typical arborization or branching of vessels on the Nabotian. This is normal vasculature. Normal vasculature branches, normal vasculature tapers. If you look at that, these are branching vessels. If you follow this vessel, primary branching, secondary branching, there is some tertiary branching. So these are normal vessels on a Nabotian follicles, which is very typical of a Nabotian follicle. If this woman has a normal cervix, she does not need referral. Nabotian follicles are a clinical diagnosis. They're not a histological diagnosis, but rarely what I do is if they are very large Nabotian follicles like this, I drain them, because then subsequently when she goes for a smear, she is not sent back for another colposcopy or another opinion, because the Nabotian follicle, at least for some time, is gone. So this is a normal cervix. Moving on. What do we think this is? Now, if you look at the cervix here, there's a little bit of a nubbin here. There's a projection here. Do we think this is normal, in which case it is good? Do we think it's abnormal, benign, or good? Good, good. Yeah, just very few bads, but primarily good. That's wonderful. That's wonderful. You're absolutely right. It is good. It's just an unusual shape. It's probably just it is a paracervix. This woman's had a delivery. It's possibly some degree of obstetric trauma, maybe here, and maybe it was sutured or maybe it wasn't sutured, and consequent to the obstetric trauma, there's an unusual projection here. It's an absolutely normal cervix. So well done. That's really good. We get lots of referrals for this. So is this good? Is it a normal variant? Is it bad that it's benign, or do we think it's suspicious of malignancy?
Got a lot of goods and Bs.
Yeah, it's predominant Bs, so that's really good. Polyp, cervical polyp. Absolutely. You are absolutely right. It's a B in my book. It's bad. It's a cervical polyp. Most of the cervical polyps are asymptomatic. They're picked up during a smear taking. Most of the time the cytology is normal, and we get lots of referrals for these. If you look at that, that's another cervical polyp. And that's another cervical polyp. I saw this woman in the clinic. If you go back, I mean, this polyp, and especially this polyp can easily be removed by you in the surgery, by GPs in the surgery. If the cytology is normal, we don't really need to see them. It's so easily done. Sponge holder, avulse it off. There's no way you can make this woman bleed. I mean, if you are hesitant, what I suggest you do is you take a cotton tip, put it in the lower part of the endocervical canal and just move the cotton tip around. That will give you an idea of how thick the pedicle is, how easy it is going to come off. And these are just so easy. And when you start avulsing it, just keep talking to the woman. If it's an endocervical polyp, she is not going to feel any pain and it'll come off easily.
Tend to twist the sponge forceps to get it off. Are you recommending that we do that, or should we just be pulling?
No, twist it. So you go into the endocervical canal, try to lock the sponge holder beyond the polyp so that you're getting the pedicle, and you just twist it off. Twist it off. They come quite easily. If the woman feels pain, you stop. And I'll tell you which ones not to avulse, and I'll tell you why they feel pain.
When we do avulse, we send them off for histology. Great, so we should send them off for histology in general practice. Sometimes we do get a bleeder.
Okay.
Should we use silver nitrate to stop that, or what should we do?
That's the answer. So what did I do for this woman? So I avulsed it and I just put silver nitrate. So it's good to go with silver nitrate on a dry base. So if you put a small cotton tip through the lower part of the endocervical canal, hold a cotton tip in your left hand and 1 or 2 sticks of silver nitrate in your right hand. So put the cotton tip, pull the cotton tip out and just push the silver nitrate just lower part of the endocervical canal, probably about 1 centimeter into the external os, and that's all she needs. She might have a little crampy pain secondary to silver nitrate, but it's very transient and settles down really quickly.
Do we need to remove them?
Well, it's not a normal thing, so it's best to remove them. Very, very occasionally you find some CIN on the polyps. It's highly unlikely with a normal smear, but yes, I wouldn't leave it there. It's a normal thing. I think they need to come off. And whatever you remove in your surgery, I would never chuck it. Everything needs to go for a histology, as Di said. There are a few questions that have come in.
I'm raising them. That's
okay.
I'm asking.
Okay, so we carry on. Okay, now this, let's hear for the good, bad, and ugly. So I want you to focus on these yellowy dots and also on this red.
We're sticking to bees.
I really like that, Dr. Whitmore. Very good.
Some of you are actually telling us what they are, which is marvelous.
Thank you. That's really good. So yeah, this is a little.
She's a nurse, an expert nurse at that.
Very good. Very good. Very impressive. Clearly, you see lots of these services. So this is kind of a little trick question. I'm sorry if it is, because these are normal. These are Nabotian follicles which need nothing. This is quite a sizable polyp. Now, I won't try and avulse this in your surgery, because when I look at a polyp like this, I won't have menstrual history. It's also possible this is an endometrial polyp. It's quite a big polyp, and looking at how angry looking it is, it might be an endometrial polyp. So I would like to take a history. And sometime when you start avulsing a polyp, if she feels pain, you should just stop, because that gives you an indication it might be an endometrial polyp. Because when you take an endometrial polyp off, when it stretches the myometrium, that's when they feel pain. And these are best done in theatre under an anesthetic. So this polyp, I wouldn't remove it even in my clinic. Okay, let's have a good, bad, ugly. So you just pop in a speculum, and this is what you see.
We're going for 50-50 bad and ugly.
Yeah. So well, we all clearly recognize this is not a normal variant. So we think either it's bad or it's ugly. This is a patient from, well, we admitted her acutely just a couple of weeks back, and she was premenopausal. She came with really heavy bleeding and with septicemia. And she grew group A strep on a vaginal swab and blood culture. So what this is a prolapsed fibroid. It's not ugly. It's a prolapsed fibroid. You need to have seen a few of these, but let me tell you how, sorry, Ty, how you can differentiate between a prolapsed fibroid and a cervical growth. When you see can you see it's quite smooth surface, and can you see that's the cervix on top? So if when you do a digital exam and you put your finger past the fibroid, with your finger you'll be able to feel a normal ectocervix, and you know that this growth is not arising from the cervix. And when you put your finger past it, you might even be able to feel a pedicle or a little stalk with which it's attached to the uterine cavity. I'm asked a question often, why is it not a cervical fibroid? Cervical fibroids don't appear like this. Cervical fibroids grow within the cervix and they expand the cervix. You'll still see a pinpoint off. You won't see a fibroid like that. These fibroids are coming from the uterine cavity. It's usually preceded by a few weeks of really, really heavy bleeding, because when the uterus is expelling the fibroid, it's accompanied with really heavy bleeding. So this is a prolapsed fibroid, and it's quite angry looking because it was infected. Any questions about this before I move on?
Not at the moment, so we'll just keep moving.
Okay. What is this? Let's have a good, bad, ugly on this one.
We're getting a bit quiet in our team. And we're going now here, we're probably going 2/3 ugly and 1/3 bad.
It's the same thing. It's a prolapsed fibroid. Of course, by looking, sometimes it's hard to judge, but a digital exam will help. You'll be able to feel a normal cervix. From her menstrual history, you might be able to get an indication of whether it's a fibroid or not. And as I said, if it's a prolapsed fibroid, they'll give you a history of quite heavy periods in the preceding few weeks. So that's a prolapsed fibroid. Bad, not ugly. You put your speculum in and this is what you find.
Got a number of bads, and someone asking whether we've really got a STI.
I like Dr. Stephanie Nam.
She may be a nurse.
Yeah, that's why I said Stephanie Nam. I checked myself and I said doctor. It is. Stephanie, you're absolutely right. This is what it is. It's a strawberry cervix. It does remind you of a strawberry, and it's trichomonas. I mean, I would do swabs for this woman, but regardless of the swabs, I would treat it. I would treat her with metronidazole for the trichomonas. And if you see one of this in your practice, you'll never forget it.
I don't tend to use metronidazole just because of people feeling nauseated with it. Could you use another product?
What do you have in mind? What would you use?
Ornidazole.
Yeah, you can use that. Yeah, you can use that. Yeah. So that's a condyloma. So if you put in a speculum and you see a whitish lesion on the cervix, it's a condyloma. It's a wart. What do we think on this one? Good, bad, or ugly?
We're all ugly. Some are feeling very, very ugly.
Very ugly.
And we've got 1 or 2 bads thinking it may be cervicitis or chlamydia.
Okay. It's really ugly. This one is really ugly. Now, if you take your mind back to the ectropion, do you remember how flushed it was with the surface of the cervix? It was at the same level as the ectocervix. Look at that. Look at the margin here, how elevated it is from the cervix. So if you see a part of the bit of the normal cervix that's visible, and you see this margin here, how it's elevated, it's almost that this is like a little cauliflower growth. That's another area which is really suspicious. And actually, if you see advanced cervixes, as soon as you put the speculum in, you think of a differential in your head and nothing else comes to mind. All you think of is malignancy, malignancy. And if it's quite advanced cancer like this one, it's also a very peculiar smell. So this is...
Do you get many of these advanced lesions now with the cervical screening program the way we have it?
Fortunately, not so many, but we still do. We know it's not a perfect system. We do know there are false negatives with a smear. Smear is not a very sensitive test. We do know cervical screening program has worked. We know that the incidence and mortality has gone down. And we're hoping with the introduction of HPV, we'll decrease the mortality further by 12 to 14%. So the answer is fortunately not too many, but we do. And I'm going to show you another one which I just saw on Friday. So that's another one. Let's see what we think. This is not good, a hint. It's either bad or ugly. What do we think?
We're going for the ugly again.
Yeah. I'm really happy that there's so many uglies, very ugly. I absolutely agree, Tom, it is very ugly. So if you look at this again, can you see this area? It's almost a fungating, it's almost cauliflower, it's elevated, it's irregular. You touch it and it's just going to bleed on you. So this woman needs a really, really urgent referral to the colposcopy clinic. This is a woman I saw on Friday in my clinic. This is a 69-year-old woman who was referred with SYN3 smear, as it said. So there was just one line on the referral that said, please see her for SYN3 smear. She was graded as P2. I like that. I like that the response is coming thick and fast. So it was graded as P2 and she was seen in 4 weeks. Have a look at that cervix. Closer look. I mean, as soon as you put a speculum in, the first thing that the smear taker should think is, this is not like a menopausal cervix. It's not an atrophic cervix. What's going on here? If you look at that area here, it's almost like it's eroded. If you look at it here, maybe the pictures don't do justice to it, but this edge was elevated and this was like a little gutter, as was this area.
With these cases, two questions. Do patients feel pain or discomfort? And secondly, how do we get these fast-tracked through straight to colposcopy?
Okay, the first question, do these women feel pain? Cervical cancers are not painful till they are invading the parametrium. If they're invading the parametrium and consequent hydronephrosis, so early cervical cancers are not painful, but they will have some postcoital bleeding, irregular bleeding, intermenstrual bleeding, and they won't have a regular screening history. If you look at the audit done in New Zealand, 83% of the women who developed cervical cancer either had no smears or didn't have regular smears. So the screening history is really important. This lady, her last smear was 30 years back. And she hadn't had a smear for 30 years. And now she's come with cancer. So no, it's not painful. What was the second question?
How do we ensure that we get rapid referral to colposcopy?
So if you tell us it's a suspicious cervix or you suspect it's a cancer, electronic referral gets to us straight away. We're going to grade it as P1. We're going to see them within a week. To make it even more expeditious, I'm going to tell you, send us a picture of the cervix. Most of the pictures in the presentation are taken on my iPhone with patient consent. So use a camera on your phone. We all have iPhones. Instead of selfies, turn it around and turn it onto the cervix. Whatever process you follow, take a written consent from the patient, use your flash, take a picture, and I sometimes have to tweak it a little bit with the settings on the phone to get a little bit more brightness and contrast. And you know that with electronic referrals, you can attach the pictures. And once we see a picture like this, we're going to see her within a week.
Thanks.
Okay. So this lady, clearly screening would have helped, but also if we had been alerted that it's an abnormal looking cervix, she would have been seen within a week. She was seen in 4 weeks. Not that it would have changed the prognosis of the presentation, but I think once you suspect a malignancy, you have to act quickly. And this is another one. Again, you see it's elevated. See, ectropions? Yeah.
They're all ugly.
They're all ugly. They're very, very ugly. So ectropions are flush with the surface. These abnormalities are not flush. They're elevated. They're irregular. And they bleed on touch. If you do a smear on this woman, she's going to bleed heavily on you. Okay. I debated whether I should leave this slide or take this slide away. Yeah.
Good, bad or ugly, team? I think we're all feeling pretty ugly. The occasional B, but mostly ugly.
So if I'm practicing in New Zealand as I am and I saw this woman, I would say highly suspicious of cancer. I would faster track her through the system. I would do urgent biopsies and I would treat her as a possible cervical cancer. But this one is actually cervical tuberculosis. It's a small print. It's good for you to be aware that sometimes it can mimic cervical cancer, but please do not delay referral or do anything differently from what you would do for a cancer if you see this cervix. The reason I put it there was just to say it can look like a cervical cancer. It's never a primary tuberculosis. It's always secondary to pulmonary tuberculosis. If you deal with a huge immigrant population, this is one of the small print. Just be aware.
Does this woman have any symptoms?
Yes, she would have postcoital bleeding and irregular bleeding. Definitely, yes. And most of the women who have genital tuberculosis, very, very rare in New Zealand, fortunately, won't give you a history definitely of pulmonary tuberculosis, because if they come from endemic areas, the pulmonary tuberculosis can be quite asymptomatic.
When we're seeing some of these ugly cervical smears, do you think cervixes? One person has asked, should we actually take a smear or should we just send them straight through to you?
I think it's good to do a smear, and in the new guidelines, I'll tell you, you as a smear taker will be requesting the cytology and HPV. So yes, please do a smear, but don't delay the referral. A cytology helps us, although if there is a visible lesion, we're going to be doing biopsies, but do a smear. Do a smear.
Even if we're concerned about quite heavy bleeding, because it would be very friable.
Well, I would do a smear, but I won't delay the referral. It's, as a smear taker, it's up to, I think you have to make that call. I mean, for example, this one, I won't hesitate in doing a smear. I don't think she's going to hose on me by doing a smear. If I see this one and I might say, oh, let me just do an urgent referral. So I think as a smear taker, you have to make that call whether you want to do a smear. And if you think the risk of bleeding is significant, then maybe you shouldn't do a smear and just do an urgent referral.
Do you think that there's any role with these ugly cervixes that we should be doing swabs as well?
No, it's not clinically indicated. There is secondary infection, but if you put in your speculum and it's really foul smelling, do it. But no, I wouldn't really say it's absolutely necessary. What is really necessary is for you to pick up that it's a really abnormal cervix, it looks ugly, and expedite the referral. That's all I want you to take away from this talk. Okay, this is just to kind of give you an idea, I have to admit this isn't the best picture. This is a pregnant cervix. And I'm not going to ask you good, bad, ugly because this isn't the best picture. So let me explain to you. This is the cervix. These are the vaginal walls. As those of you who've examined pregnant women, you would have seen that the vaginal walls just come in the way when you put in a speculum. This is the os, and that's a thick cervical mucus plug there. To an untrained eye, they would put in a speculum and look at these nubbins, little bit of bleeding, little bit of that. That's just a normal change on the cervix in pregnancy. It's a decidual reaction because of the really high progesterone levels coming from the placenta. This is absolutely normal. And that's why pregnant women, even when we see them for colposcopy, we make sure that somebody really experienced examines them, because it's very easy to label this as abnormal. This is a normal decidual reaction on the cervix.
We've had a question in. What is the significance if you get endometrial cells on your cervical smear result?
Okay. In women over 40, endometrial cells are normal. Depends on what phase of the cycle you take a smear. If you're done in a secretory phase, finding endometrial cells is absolutely normal. What you would want to know is whether the morphology of the cells is normal or not. They can even be found in postmenopausal women if they are on HRT. In my practice, if I find endometrial cells, one thing I do for sure is I go into the details of the menstrual history and see if she needs an endometrial assessment. If the menstrual history is normal and the endometrial cells are normal morphology, she does not need any further investigations.
If a woman comes into you and she is pregnant and she's not been having cervical smears, should we be doing cervical smears on these pregnant women, or should we wait post-delivery?
If you say she's not been having cervical smears and this might be the only opportunity to do a cervical smear, I'm hoping she would be less than 20 weeks, in which case you can sample the entire transformation zone. You know, the further they get in pregnancy, and if you have a cervix like this, for example, let's just assume this is a woman you're seeing who's not had a cervical smear. Look at the vaginal walls coming in the way. If you want to do a smear, you have to go to the entire transformation zone around the whole os. You're going to take an inadequate sample. You're going to falsely reassure her and yourself that the smear is normal, whereas you haven't even touched the area on this side. So I think it's a combination of, yeah, opportunistic screening is good, but how adequate is your smear going to be? As a smear taker, it's your responsibility to make sure you've taken an adequate smear. It's not the lab's reporting that tell you the smear is adequate. They just look at the number of squamous cells there are for reporting. So that's your call, but I would rather wait till she delivers.
Do we take a smear then at the 6-week check? Is that ideal, or do we need to wait longer?
It's ideal to wait for 3 months, but if you think you might lose her and she is not up to date with her smears, 6 months is absolutely fine.
If we have no transformation zone cells seen, should we actually repeat these smears?
As a smear taker, you have to go back and think why there are no transformation zone or endocervical cells present. If it's a very stenotic os and you haven't used an endocervical brush, then you know that you possibly haven't touched the transformation zone. But if it's a normal cervix and you know your smear taking technique has been good, then no, you don't need to repeat it. If this squamous cells are adequate, then you don't need to repeat it. If you take your mind back to the first slide I showed you, the ectropion, the very first slide, if you take a smear just touching the columnar cells, tell me if you want me to go back and show you that slide.
Could you? Yes, I'd like to see that one.
I am going to take you back and show you, because that's really important, the adequacy of the smear. Okay, now if you took a smear from here, this is the columnar cells. You take smear from here, you haven't even touched the transformation zone. The smear is going to be reported as endocervical component present, and you will be falsely reassured that you've sampled correctly. So as a smear taker, it's your responsibility to cast your mind back to the smear that you sampled, what instrument you used, and whether you can reassure yourself and the woman as to the adequacy and the normality of the smear. So endocervical component, the lab's going to say, yeah, adequate, but you haven't done a proper smear, you haven't even touched here.
Yes.
Okay. So that would be my answer to lack of trend. Sometimes I see women in the clinic who've been referred for no transformation zone component seen, and I see them and the cervix is completely walled off. They're gone for years without a transformation zone component, and clearly it was the smear taker's responsibility to go back and look at the cervix and see whether I'm actually entering the cervix, whether I'm actually sampling the transformation zone. So as I said, you have to look at the patient and decide. Okay, carry on. Okay, now it's very well listening to all, listening to all this, but this is a resource which has been developed by the Victorian Cytology Service. So if you Google Victorian Cytology Service and the cervix sampling card, you can have this as a ready reference in your clinic for smear takers. And this is the link, but you can Google that. And as I said, I've already mentioned before, send us a picture of the cervix. Now that's all about the good, bad, ugly. Now I'm going to go on to the immunization and the changes that have taken effect from January this year.
Just so you're not feeling anxious, we will put that website on the Goodfellow page for you beside this presentation, so you'll be able to access that.
Thank you. Okay, so the HPV immunization or the Gardasil, which was a 4-valent vaccine, has been available in New Zealand from 2008. What's changed from January this year is 2 things, or actually 3 things. One is we've got a new vaccine called Gardasil 9, which covers for 9 kinds of HPVs, of which 7 are the high-risk ones responsible for cervical cancer and 2 are responsible for genital warts. Universal male immunization. So New Zealand's one of the 6 countries where we offer male immunization, and the age group now is 9 to 26 years. So young people 9 to 26 years are covered and it's funded. The doses are funded. For women older than 27 years, transplant patients or post-chemotherapy, even for them it's free and it's funded. So 2 doses for younger people and 3 doses for older. So initially it was 3 doses for everyone, but for 9 to 14, it's 2 doses, and that's 0 and 6 months, and that's 0, 2, and 6 months.
Just looking at conversion rates, is there any advantage in doing this earlier in children in terms of conversion and sustaining protection? Or is there no difference by age?
So the earlier you give Gardasil, the more effective it is. It's ideally given between 9 to 11 years because the immune response is really good. And I have some data to show you, to tell you about if they were given below 20 years, if they were given before 20 years, the high-grade CIN was reduced by 40 to 70% versus if it was given after 20 years, high-grade CIN reduced by 20%. So the younger you catch them, the better it is, the better the immune response, more sustained the response. So catch them young. Now a little bit about Gardasil 9, as I said, that it covers high-risk types and 2 low-risk types. These high-risk types are responsible for 86.5% of the cervical cancers in New Zealand and Australia. Now, Gardasil 9, as per Merck, protects against 90%, but looking at the prevalence of the HPV types in our region, we are protecting them from 86.5%, which is way better than when we were doing 16 and 18, which covered about 64%. As far as the side effects are concerned, yes, there is increased injection site reactions, but the systemic side effects are similar compared to Gardasil 4. question I am often asked is this: do women who've been fully immunized with the older vaccine, do they need to be revaccinated with the newer one? And the answer is no, they do not need to be revaccinated, but women who've started their immunization with Gardasil 4, and if Gardasil 4 is not available now, then they can complete their course with Gardasil 9. Whether the additional HPVs in Gardasil 9 are going to give them the protection, we don't know. But it's not recommended that the old cohort be revaccinated.
We are now getting patients coming in informed and saying, I'd rather wait till I could get Gardasil 9. I hear you're cleaning out your stock, doctor. What should we do with that older stock? Have you got any recommendations?
Yes. Most of the HPV-related cancers in men are related to HPV 16 and 18. 90% of HPV-related cancers in men are because of 16 and 18. So you're being absolutely fair by giving that old Gardasil to younger men and reserving the Gardasil 9 for women.
Excellent. What about patients who have had an abnormal smear? Should we, the older woman over the age of 40, should we be giving them Gardasil to help reduce their risk?
Definitely. Now, the natural infection does not cause the same level of immunity as the vaccine does. And that's because of the way the natural cycle of HPV works. HPV is transmitted by skin-to-skin contact. It sits in the cervix. There isn't a viremia to evoke an immune response. So for that reason, women who've had a natural infection with a certain HPV type stay at high risk to be reinfected with the same HPV type. More so because we go in and screen them and treat them, so we've actually interrupted the natural cycle of the HPV. So these women, even if they've been infected with, let's say, 16 or 18, still will benefit from the immunization. Of course, we know the most benefit is in sexually naive population, but there's a definite benefit in women who've been infected already, and even in older women. There's more and more data coming out now that women who have been infected and are older benefit from the vaccine. Now, why I put this slide in is that our coverage of vaccine in New Zealand is really low. Australia is at about 72%. We are at about 53%, and it's quite static. It's not climbing. And there is really good data to suggest that healthcare professional recommendation influences parents' decision to vaccinate their children. There's a study from Australia and from US which supports this. So I know we all are pressed for time, but this is really important. If you can have some patient information leaflets in your surgery, you introduce the idea to the patients and give the leaflet, that'll have a huge impact.
I think that's incredibly important that we are recommending proactively Gardasil to the population. One of the things that we've been asked through your questions is about older women again. And there is the women that are restarting new relationships, having had breakups and re-entering the market. And should we be vaccinating these women proactively?
Yes, you should definitely be recommending vaccination for these women. I'm all for it. Women who are entering a new relationship, or women where their male partners you suspect might have other partners, definitely benefit from Gardasil. I have recommended to 2 women recently, and I think you're absolutely justified, and actually you should be promoting it.
So we've got this major breakthrough with younger women, but not to forget for older women as well. We've had a question about for men. When should we really ideally be vaccinating these boys?
Exactly the same. Younger the better, because you want to immunize them when their immune system is very receptive, when it's going to have a good antibody response. I won't go into details, and I'm sure you know that much more than I do, but the oropharyngeal cancers, the non-smoking one, HPV related, are on the rise in men, and these men have a higher prevalence of oropharyngeal HPV carriage compared to women and don't mount the same response compared to women. So younger the better. How long does the immunity last? It's expected to last lifelong, but on the ongoing clinical studies, the immunity hasn't waned in 10 years. So
just another question about vaccinating with Gardasil. If we have sent a patient to the hospital and they've had CIN3 and they've had a LETS procedure, would you be giving them the Gardasil at the hospital, or should we be following up in the general practice?
I would advise her to get in touch with a general practice. We don't have facilities for Gardasil because Gardasil is given through the school immunization program and through primary care. It's not given through hospitals. It's not given through tertiary services. And also, if it's less than 26, it will be funded. And if I send a woman to you, I would tell them that it's if it's over 26, it'll cost about $500. Yeah, so I'll refer them to you, but I'll give them all the information and the education. We're nearly done. This is my last slide. This is just to make you aware of what changes are coming in 2018. We are expecting these changes to start in the latter half of 2018. The main change that's happening is this. We've done cytology and read cytology for years. It's going to be HPV screening. The sample, the way you obtain a sample from the cervix is exactly the same. It's the same instrument, liquid-based cytology, but it's going to be primary HPV screening followed by cytology. And the age is changing if you see here. We're not going to be starting at 20, we'll be starting at 25. And we're not stopping at 69, we're going to carry on till 74. And then at 74, we'll give them an option for a HPV exit, see if they are HPV positive. Instead of 3 yearly, it's going to be 5 yearly. Lots of data to support that HPV, if they are negative, it's absolutely fine to do it 5 yearly. And we're going to, once they are HPV positive, the lab is going to look at what kind of a HPV it is. Is it 16, 18, or it's other? And as I say, not all HPVs are born equal. 16 and 18 are the most aggressive ones, and they are going to be referred straight for a colposcopy, whereas the other HPVs are going to have a repeat smear. So this will give you a broad overview of the change of the age, the change of the frequency, the HPV, and the different kinds of HPVs.
Is there ever going to be a chance for women to actually self-sample?
Yeah, there is. It's not going to be a part of the national guideline, but there is funding, and that research is going to start in New Zealand as well. There are groups of women we just can't engage into the cervical screening program, and so yes, eventually we hope that women who we can't engage, there will be an opportunity for self-swab for HPV. It's coming, but it's not going to be a part of the pathway from next year. Oh, by the way, Australia is going to change to HPV screening from December this year.
Fantastic. One of the groups that I always struggle with is the woman who is 45, 50, they're hating having smears, they've had one sexual partner, they've never had an abnormal smear in their 25 years of having smears. And they say to me, I understand in Scandinavia I'm identified as low risk. Can I stop having smears?
I get asked this question so many times. Okay, what I would say is, instead of cytology, do a HPV. Although the guidance is not there, HPV is a much more sensitive test than cytology for screening women. But you have to remember the HPV has two peaks in a woman's life, in younger women and after 50 in adult life. So she might not have HPV at this stage, but she might have a HPV when she gets into her early 50s. So if she is HPV negative now, you can forget about her for 5 years, and she might be more accepting of a 5-yearly screening than a 3-yearly screening. And the other thing I'm just going to stress here is, when you do smears for older women, can you please give them Avastin? because these women are hypoestrogenic, the smear is extremely uncomfortable for them and it becomes really hard to interpret. We get these smears showing Ask H, which are just because of atrophic changes, and they get referred for colposcopy. So the new guidelines are going to state that they should have Avastin every night for 3 weeks before they have a smear.
That's an excellent point, actually. So what we're saying is, with those older women, perhaps to consider testing for HPV, certainly using Avastin. What happens if that, you said 2 peaks, and I'm interested in that. If the woman has stopped being sexually active, does she need to worry about a second peak?
Yes, she does, because our understanding of HPV has changed so much over the years. In the past, we used to think, oh, women have these HPV when they are younger. Less than 30, the prevalence is about 30%. So, and as they get older, HPV wasn't detectable, and I thought, oh, their body has cleared the virus. But now we understand it possibly stays there at a very low level, which is clinically undetectable and not clinically relevant. And then they have a peak later on, and it's not because they've acquired a new sexual partner. It might be because that HPV is lying at a low level but has another peak later. The guidance from Scandinavia or guidance from WHO isn't that after 50 you just stop screening. It is that if women have had, this is pertaining to cytology, if women have had regular 3-yearly smears till 50 and they've had a normal screening history, they can go on to 5-yearly smears. That's the guidance. So yeah, they are low risk, but it's not that the risk is nil.
What about the 1 in 10 women who may have had breast cancer? Should they worry about having Avastin cream for 3 weeks?
A short-term course of Avastin is absolutely fine, even for women with breast cancer. They need some convincing, and I have had women who just won't use it, and I'm absolutely fine with that. But if you give them the knowledge and the information, that it's absolutely fine for a short course, because there's hardly any systemic absorption of Avastin. That's absolutely fine.
Thinking more about the men again, with the HPV, can we do oropharyngeal swabs for HPV in these young boys?
Okay. I am not sure how reliable they will be in picking up, but one of the questions that is asked is that if the oropharyngeal cancer is going up, why, and it's in the mouth, just like you can see the cervix, why can't you have a screening program for oropharyngeal cancers? And the problem is, I'm not an expert in this, but I can tell you from my reading, the oropharyngeal cancers develop in the posterior part of the tongue and the palatine tonsils, which are not easily accessible. So I think extrapolating from that, possibly HPV swabs wouldn't be very helpful, but how is that going to change our management anyway? I mean, even if there is HPV carriage, that doesn't change our management in any way. We're still going to do what needs to be done. Because there is no screening program and they are at high risk, primary prevention is the way to go. That is why push immunization for these younger men, because primary prevention is what they need.
We're going to draw this session to a close now, and to thank you all for staying. We've still got an audience of 100%, which I think says that Jyoti has done an amazing talk tonight. I'm so grateful. I think we've covered the good, the bad and the ugly extremely well, and the changes that we are expecting in the future. We will make sure that the overheads for this are available for you. Please keep in touch with the Goodfellow website. There is always new and exciting information there. So thank you very much, Jyoti.
Thank you.
And it's been a pleasure chairing tonight.